Hi, this is the Cancer Patient Lab, and this is our weekly session. Today, we're happy to have Frank Nothaft with us. I'll introduce him in a moment, but first, the disclaimers. There are two that we always have. First is this is medical information, not medical advice. We try to give people information that they can take to their medical team and to spur their thinking. And the second is that this is going to be made public. Everything you say and your image and anything else will be made public. So if that's a concern for you, then you can not say anything and hide your image. But this will be made public, and anything you say will be made public. I'd like to introduce Frank Nothaft. I got connected to Frank when he was at Databricks back now probably four plus years ago, when I was looking around at interesting companies that were doing innovative things when I was writing articles for the Harvard Business Review. And Databricks was doing open source computation. They would do things like, if it took 8 days to run a complex computer program, their software would make it run in 4. It was that level of complex. We always do, as consumers, we do everything in seconds, but they were dealing in, days of computation. And then followed him, kept in touch with him as he started working at Tempus. Tempus, as we all know, is the diagnostics company that many of us have used, based in Chicago. And a friend and company that is pushing the envelope in new tests and new information to help patients guide their care. Frank left there a short while ago, and we were catching up, and he explained that one of the things that he had learned is that there's a lot of information that could help patients, but it's not easily accessible to others other than those with his deep bioinformatics and research background, and wants to open up data and democratize its access so that more patients, like the kind of activated and engaged patients in our community, can use it for guiding their care, or if they're a caregiver for their loved ones. So with that, I'll turn it over to Frank. And this also, by the way, fits into a passion of mine, which is generally, how can we disrupt healthcare by giving more information and power to patients? So, Frank, it's loading here. My screen shows loading. Are we having a technical problem with getting your slides to load, or? Because I thought I saw them for a moment.
Yeah. Does it show? Let me just try. Does it show now? I can try resharing real quick.
I think try resharing. That might be the trick.
Let me go for it. All right.
There you go. Okay.
All right. Great. It seems like does it still show now, or did I lose you all again?
It's showing loading now.
Okay, great. It seems like Google Slides doesn't want to show it in the full screen mode. Let me just go ahead and snap some of these toolbars to the side, and then you zoom to fit. All right. Sorry there. I apologize.
No worries.
All right, let me just try one last reshare. All right. Does that work now?
I'm seeing Frank Nothaft has started screen sharing, but I'm just seeing the black screen.
Sorry there. View. Slideshow.
Brian suggested going to full screen and then select the screen when you hit share.
That was what I was just trying to do. Let me see if think I may have just figured it out. All right.
There we go. That did it.
Excellent, excellent. It always that permutation. I was telling myself earlier this morning I should have made a PDF and just presented off the PDF. Fewer things go wrong that way, but thank you for bearing with me. And thank you all for having me today, and thank you for the great intro, Brad. Um, I titled this "Opening Up Access to Cancer Data for Patients and Caregivers." Opening up data is a great ambition, but I think the real question is how do we turn data from just pure information into actual actionable insight that we can use to drive our care in a way that is well aligned with our goals for the condition that we have. And that's, I think, a very amorphous question. It's one that I've been thinking about, struggling a bit with recently. I'd really love to get feedback from you all on, areas that you think could be really helpful, areas that you think data today is hard to use to drive decisions that you feel maybe slightly unempowered to do to make, or like you don't have good information, good information and good data to support you in deciding. So I'd really love to make this very interactive. And please stop me at any point in time if you have feedback, if you have a thought, you have a question. I'd really appreciate that. I'll start real quick by talking a bit about myself, and I'll talk a little bit about actually what kind of led me to this this kind of next phase of my life. I'm originally an electrical engineer, but a little bit over a decade ago, I was talking with a computer scientist, Dave Patterson at UC Berkeley, and he had just put out this really thought-provoking, article talking about, computer scientists might have the best skill set to make an impact in cancer care, and don't we, as ethical human beings, have a responsibility to pursue that? That really resonated with me, and over the last 10 years, I've spent my time kind of working across, diagnostic testing and research in both oncology and genomics, across academia, where I was at Berkeley, and then at a couple of different startups, Color Genomics, where I worked on some of their very early hereditary cancer risk tests, Databricks, where we did a lot to help industrial organizations, both pharma companies and diagnostic companies, do large-scale disease research and testing. And then most recently, I was at Tempus, supporting a lot of our basic data research, basic and translational data research. Worked on a platform called Lens that tried to make the data at Tempus accessible at a true population level to any qualified researcher that we were working with. For me, over the last decade, there's been kind of one working thesis that I've kind of been, repeatedly hitting on, and it's, open source software, open data is a really powerful lever that we can use to make, this really powerful, really high impact data accessible to a much broader range of people who have important decisions that they want to make, whether it's for their care, whether it's for research into understanding a mechanism of, what drives cancer, whether it's research to actually translate some of that basic insight into a new therapy in the clinic. But for me in my next phase, my real goal is to go ahead and make it easier for patients to work with their diagnostic data, work with their EHR data, and make empowered decisions about their care. Something that's kind of led me here is a couple of things in my personal life. About 3 years ago, my daughter, then my wife and I were all diagnosed with autism. And autism is an interesting condition because a lot of the research and a lot of the clinical practice is actually driven not at all by patients. It's driven in a way that some patients see very controversially, not aligned with what their interests are, what their needs are, what the values that they espouse are. But it also, for us, was this really interesting time. Both me and my wife have a medical background, and we found ramping up on the literature to be, just a really big challenge for us. And we spent a lot of time kind of making sense, making heads and tails of the data. Again, we're really lucky, we have that background, but for somebody who doesn't have that background, it's easy to see the research, not understand where it's coming from, the biases in it, and get misled and do things that aren't necessarily aligned with your values as a patient. And then for me, as somebody who's worked in the diagnostic space, I've increasingly found that, I am that person where when someone close to me has a question about a diagnostic, they'll call me and they'll ask questions. And over time, I found, I feel really privileged. I've been able to help people in my life who have those questions. A person really close to me was, they have 3 sisters who have had breast or ovarian cancer. They were looking at getting, diagnostic testing in that space to understand if they had, BRCA variant that would put them at risk. And they weren't, they had a lot of questions that they weren't able to get the answers that they weren't able to really get answered by their doctors, given the time they were spending with them. And I had this realization, there are probably many patients, probably 99% of patients have gaps like that, where they have questions, they're struggling to get answers. It feels like something that we really, we as a field, those of us who've worked in diagnostics, need to take a better patient-centric perspective and build things that really empower patients to center their values and their needs in their care. So that's just a little bit about me and kind of what's led me down this path. I'll talk a little bit about some of my experiences in the personalized medicine space and what I see as both the promises and the perils. And I'd really love feedback on this because this represents my findings, my perspectives. But I'm really looking to generalize this and get other people's perspectives brought in. One of the things that's really stood out to me as the promise of personalized medicine is that we're able to take, the evidence that we know from the literature that combines the research evidence that we have, all of that, both basic clinical and translational research that we've done, people have published about, we have good understanding of. We're able to blend that with, what the patient is looking to get out of their care and what the clinician has seen in the clinic, and hopefully using, all of these precision diagnostics, these next generation sequencing tests, new pathology algorithms that we see in the lab. Hopefully we can use that data to get to a point where we're picking a treatment that is most likely to meet the patient's goals for their treatment in an effective and safe manner. That's in my mind the promise of it. I think one of the challenges that we found, in especially speaking from an industrial perspective, what still surprises me is that about 50 to 80% of patients wind up not getting the correct medicine, quote unquote, correct medicine for their condition. And this comes from a number of different gaps that we have. For instance, some of the time patients wind up getting not the correct set of diagnostic testing that might be indicated for their condition. Some of the time that's because the diagnostic testing is too expensive and thus winds up being inaccessible. Some of the time the diagnostic test is not easy to access at the at the hospital or through the clinician that they're going with. Some of the time, there are other factors that lead into this. And then, even in the cases where the patient does get the correct diagnostics, we actually hit this very interesting gap where the standard of care is moving so quickly in oncology these days with new medicines coming out, better understanding of side effects of medicines as they have, gone into the market, been administered to more patients, and we've seen how patients actually fare in the real world on those. So it's hard for physicians to go ahead and keep up with the literature. It's equally hard for patients who are trying to make these decisions to understand the full spectrum of what diagnostics, what therapeutics, what other interventions might be eligible to them. If they go on, if they go on a medicine, what are some of the side effects that they might have? How can they hopefully mitigate those side effects so that they get the best possible response to the medicine? And you also have kind of an interesting side effect that kind of comes out of how we typically approve medicines these days. We really heavily have indexed on overall survival and progression-free survival as our endpoints in oncology when we run clinical trials. It makes a lot of sense. They are, the classical endpoints. But some of the time that may lead to a quality of life expense that isn't necessarily evaluated in the phase 3 trial. Sometimes that may lead to therapies that are incredibly economically expensive. So there winds up being, I think, a large number of factors that lead to this gap. And some of these feel to me very readily addressable. Others of these, I think, are very hard, complex, systemic ones to go ahead and address. But especially where we have, knowledge that is being generated that we're struggling to disseminate, like, updates to the medical evidence, updates to clinical guidelines, information about new diagnostics and new trials that come out. Those feel like a very readily solvable problem in the software space. I'll pause here for a second. I'd really love to get any feedback here. I'm sure that I've missed things, and would love to get any thoughts.
Let's use the raise hand feature for people that want to comment. I've got 2 quick ones, Frank.
Please.
So everything here is great, but I would also add personalization versus population-based.
Mm-hmm.
So and it kind of goes to the point you have about how research is designed. Research is designed to work at population levels, not at individual levels. And so what's best for a patient who doesn't fit the population criteria puts them outside of access to treatments.
Yeah.
And it also breaks the level of personalization can break the traditional research paradigm. When you get down to drug combinations unique for each patient, then how do you aggregate them up to come up with some general principles that allow clinicians to deal? And the other is one of my other favorite ones is real world evidence versus clinical trials. Patients need to make decisions, and it also comes to patient values. Patients need to make decisions now. If I look at the patients in our group, they're interested in things that are going to be available now or in the next 6 months. If you tell me that there's going to be a randomized clinical trial that'll be out in 5 to 10 years, that's beyond their horizon. It's nice that it's in the lab. It's nice that it's going that way, but it's not going to be accessible and useful to me. So the needs of patients in terms of time, and therefore I want to see now, right now, patients like me who are taking this drug and what their experience is another gap in the system, because the only evidence that qualifies as real world as evidence is peer-reviewed clinical trial evidence. Real world evidence is given short attention.
Yeah, definitely agreed there. And that feel particularly passionate about that last one, because that was a big problem that we were trying to work on at Tempest. And I do think there's there's increasingly kind of regulatory openness to that, and you're seeing more and more places where it is used, whether in submissions, but it's definitely a gap, especially in terms of empowering people who are making treatment decisions to use that evidence has been, in my experience, still a big gap.
Okay, we have 3 raised hands. Brian, you're up first.
Hi, Frank. It's great to meet you. And this is a really meaty topic, so I'll try to make it quick. Just the other point that I would make is that even when patients are armed with data coming from sequencing their DNA or RNA, doctors sometimes just don't know what to do with it as well. And particularly as you get into, RNA or whole exome sequencing, there are so many flags that come up for them to be able to use that information to drive personalized treatment options. There's a whole host of barriers to leveraging this data. We've definitely pursued many different angles. One of the things is just finding a doctor who actually can understand it, believes it, can interrogate it, and can then act on it. That's a big problem.
Yeah, I think that's a very spot on call out, and especially as we move into kind of increasingly complex biomarkers, like some of the complex gene fusions, things like HER2 low in breast cancer. Those require like even further understanding to interpret correctly. And there can be a combination of getting an oncologist as well as a pathologist who feels comfortable working with those. I'd love to dive into that more deeper.
I know Rick's got his hand up. He'll probably talk a little bit. We've done a lot of work with Josh Bell, and I've been walking I've been walking the halls of Tempest for about 6 or 7 years, so very familiar with what they do. Anyway, I'll turn it over to somebody else.
Go ahead, Rick.
Hey, Frank, interesting background. Pretty cool, man. I'm an EE. Got into bioinformatics probably a little bit like you. But I'm curious what you feel is of interest to this group, and I'm interested in your new company. So we've heard a lot of stuff, very interesting, but I think our group, or for me, is like, what can you do for us? And even if it's out in the future, a vision, a movement, but I don't see that yet. I see problems, I see gaps. So I'm wondering what hope or value you can bring to this group. So we're advanced cancer patients, out of standard of care, love to interpret data, don't have a lot of data necessarily. Maybe liquid biopsies would be something that probably everyone could get. But anyway, I'd like you to tailor a little bit towards what you can do to help us, if you don't mind.
Of course. And I actually have a slide in a minute where I'll talk a bit about what I've been thinking about and some of the open areas that I'm still trying to understand whether it's valuable. So I'll dive into that in a moment.
Good.
Thank you.
Roger, you're up next.
Just a quick comment. I was on a podcast this morning. I listened to the cancer podcast. It was all about artificial intelligence and cancer care and where that's going. And since I become a patient, one of the things, I was just down at the Society for Immunotherapy for Cancer conference in San Diego last week, and one of the things that becomes apparent to me is that there is just so much data out there, and there's so much information. It just seems it's going to take computer modeling just to organize it all. On the podcast, the doctor was commenting as I can't possibly read all the papers and studies that come out, but a computer can read it and tell me if it's important and summarize it for me. So it feels to me like that's going to be a really big part of managing the data going forward, and personalized care as well.
Yeah, that I would definitely agree with that, and that's actually been a big point that I have been thinking a lot about, because if you think about PubMed, like, one is an amazing asset, but unless you have a lot of time to kind of separate the wheat from the chaff, as well as good medical and statistical background to understand biases present in a study, what is the level of evidence that the study is creating, it's really hard to work your way through. And I myself have gotten lost in it. I've seen other people close to me get lost to it. Candidly, it's been a big problem that we would hear from people when we were at Tempus. And that is actually, I do think, kind of a big part of what could be on offer, because I'll talk to this a bit in the next slide, but literally one of the great things that being in an org like Tempus is you have a great network of people who are subject matter experts in really fine areas of minutia, who are up to date on the latest and greatest literature. And they are kind of your chat GPT for for the literature. I think figuring out a way to go ahead and scale that would be valuable. But it's I think a question of, like, how accurate does it need to be, and how do people want to interact with it? Like, how would people actually use it in their day-to-day, whether they are a clinician or a patient. That's an area that I'm a little fuzzy on right now.
Okay, Jeff, you're up.
Hi, Frank. Thanks for joining us.
Oh, thank you for having me.
So this is more of a suggestion. I have a
Please.
behavioral health background as primarily as an administrator. And one of the things that we recognize is, whether it's somebody with a kind of a life-affecting mental illness, going to see a physician, a psychiatrist, a therapist. Clients don't always know, or patients don't always know, what they want, what to ask. And there's also the differential power dynamic between the physician and patient. I know I went through, I think, 3 oncologists before I found the one that I'm currently working with, and have been for quite a while. But I think in this group, we're all somewhat very capable of doing that for ourselves. Many people, I would even say most patients, are not. So one of the strategies that we use in behavioral health is to have a kind of system navigator who can help people talk to physicians and advocate. And I guess what I'm wondering in this instance is, with physicians being as busy as they are, and as often I'll tell my primary care doc what I want and what I need, and I'll get it, but there won't be much discussion with it.
Yeah.
Is almost like an interpretation specialist who understands how to use this and can translate it, can kind of do that synthesis that you were talking about in your slide with the 3 different areas, and can talk to patients and can talk to physicians and help kind of digest, here's what we see from this. So anyway, that's my suggestion. We see it work pretty well in behavioral health. It helps people understand what they want and to some extent get what they want. This is a different level of detail and specialization, but it seems like there's almost a niche for that medical role to span those three areas and not just say physicians can get it, they can click on this, they can get the summary, because they may not even know what the summary means or the implications of it, if they even have time to do that. So
Yeah, no, thank you for bringing that up. And, that I think that's actually a really spot on point. And candidly, I think it could be useful really in all diagnostic specialties of medicine. Oncology, I think, is a particularly relevant one because, it's very common that a patient is working with, even if they're working with a single oncologist, there's a large care team. There may be multiple doctors, especially diagnostic specialists like a radiologist or a pathologist, who are supporting the care of the patient. And there was a example that I had kind of run across, not in oncology, but another medical specialty, where someone close to me, they had gotten kind of they were working with a cardiologist and another diagnostic specialist, and they were getting kind of different, the two specialists were looking at this differently with different diagnostic modalities. One was getting a very good, very positive readout. The other was getting a very negative, very concerning readout. And they were struggling with how to go ahead and interpret this, and actually led in a very adverse way. And it's particularly challenging too, because I think a lot of right now, like our standard for this in kind of patient care, patient routing, and I say this like not flippantly, is, oh, go ahead and send your doctor a message in my chart. I've definitely, when having to get diagnostic testing, when I've had concerns or questions about a readout that I've gotten, my recourse has been, oh, send the diagnostician a message through my chart. They'll get back to you next week. Which is, I think, really challenging as a patient. It doesn't kind of give you that sort of interactivity that you often need to really get to the bottom of something. And it can feel like a really big mismatch between, kind of your urgency and the urgency that the rest of the healthcare system is giving you.
If I could just clarify, Jeff, what you're getting at, is it you're saying that the interface to the information has to be thought about, and that there's has to be, is in the same way there's personalization of the treatment recommendations or the information that's coming to the patient, there also has to be personalization in the interface?
Yes, it's again, from my experience, there are these positions that I would call spanners who, have a foot in different areas, and you might say case management, but that's not what I'm talking about. It's somebody that has enough information about each area and can make those connections. I think in the medical field, that's often a nurse who does that. And some nurses are very skilled, and some nurses are not. So, the quality of that isn't necessarily good. And I'm just wondering if, again, if there's a specialist role that can bridge that gap between the patient, the AI readout about here are the best options, and the physician who likely doesn't have time even to sit at a computer and put all the data in. And I think there's also some concern about the black box, what's the quality of this information. So anyway, that's what I'm getting at, is kind of the creation of almost a specialty role in this, at least at this point. In behavioral health, it is, and this is kind of has always been shocking to me. It's about a 15 to 20 year period of time from a well-established, well-researched intervention to it being commonly used in routine community mental health settings. We may be speeding things up here with AI, but so thanks, Brad, for helping me clarify what the suggestion was and what the kind of need area that I was seeing.
Great. Bob Germankin, you're up next.
Yeah. Okay, so I'm going to shift gears with my question. So there's a lot of data out there that I've gotten, but you got a lot of new companies coming on board. And what happens when you get conflicting data from different companies? How do you reconcile? So in my case, I had PDL1, which is a marker used, came back negative by immunohistochemistry by a company called Caris on my tumor. Boston Gene did RNA sequencing and came back 100%. So it's like, okay, the RNA is ready to make 100%, and yet when the actual protein, it's not being at all. And the company, Boston Gene, couldn't rectify that discrepancy. And I'm sure you get multiple reports, you're going to find multiple discrepancies because everybody's assays are not the same. Everybody's interpretations are not the same. What's a patient supposed to do with that?
Yeah. I think it's a really good question, and it's candidly a really tough one. We did a number of different kind of looks at that in our time at Tempus. And some of the time it kind of comes down to figuring out like what is what is the most trustworthy test for a diagnostic purpose. For instance, for something like PDL1, like a cell surface protein, that might be a place where IHC would be a better readout than RNA-seq. I'm not a PDL1 expert, although I've done some research in the space, so don't take that as evocative and not a specific recommendation. So I do think it is a little bit of kind of coming up with guidelines for how to interpret those conflicting things, but honestly, you do see it in in people who go through concurrent NGS testing. Some of the time that is just that things are within the margin for error, especially if you're looking at low variant allele frequency mutations. But honestly, it's a really good question that I don't have a great answer for.
Fair enough.
Yeah, it's honestly just a very hard one, and I realize that's not a very helpful answer.
So back to you, Frank. I think you have some more slides.
Oh, could I chip in here?
Please.
I agree with Frank. IHC is generally regarded as more reliable. It's weird that you see 100%. Now that's a weird, just to clarify, that would mean what? In RNA-seq land, that would hopefully mean that you're a high expressor. So 100% compared to Tempus's cohort. So out of, let's say, 1,000 prostate cancer patients, that 100% might mean you're highly expressing PDL1 compared to those patients. So that's one I would think that you would get from that. But the reason I raised my hand to chirp in here is that's a point of 20,000 genes that Tempus is counting the expression of. So if I were you, I would ask to get the RNA-seq file It's just a little CSV file of the 20,000 genes from Josh and say, okay, does this make sense for the rest of my data? In other words, you could do immune deconvolution and just see, do I have T cells in my tumor microenvironment? Do I have CD4, CD8, Tregs? What is the immune deconvolution of the 20,000, and you only need like 600 to make that deconvolution. But in other words, query that RNA-seq data a little deeper than the point. I think you have the data, or you can get the data. That would help clarify.
Yeah, and just to echo on top of Rick's comment, especially with like RNA-seq, it's particularly challenging to interpret because, oftentimes it's interpreted, as Rick was saying, to like the distribution of patients in that cancer subtype, and that can be the right approach in some cases. In some other cases, you would actually want to compare to like a panel of quote unquote healthy patients that have been sampled from your tissue type, which is challenging. Sometimes people will look at an asset like the GTEC data set to do that sort of a comparison, because there can also be kind of tissue type to tissue type biases that will cause gene expression to look a little bit wonky. That's like most common in like hepatic cancers, but I wouldn't be surprised if there are other areas that it's a challenge for as well.
Did that help? Or
Yeah, I think I did. So the PD-L1 immunohistochemistry came from Caris. And I contacted them and they're like, everything is in the report. So you're saying that they have more to offer, but it's more in a different form.
well, where did you get the 100% from? Was that from Caris or from
Boston Gene. 100% meaning compared to gene expression compared to their cohort of prostate cancer patients.
Okay. So you have two companies, two different, yeah. Can you look at the IHC? Is that possible? Would they be able to share the actual slide or the image?
I don't know. I mean, I can go back to Caris and see if I can get some raw data.
It's pretty easy to look at. I mean, you just look at it and, usually typically it's a brown stain.
Right.
You look at it. I got a bunch of brown there or no brown or,
Yeah.
it's actually a little bit trickier because there's two different kind of stains.
Rick, could we, I want to get back to Frank and get back to the agenda. Thank you.
Maybe we'll talk offline about how I get the raw data out of Caris.
Okay, Frank, you've got 15 more minutes, so and I know you've got a few things to say. See if you can rapid fire.
Of course. And I do think actually it is kind of a good segue off of that last point, because one of the things that I will just like call out, if you're in a tech savvy oncology org, and I think it's a company like diagnostic companies that have good technology build outs, like Tempus or Caris, or really most diagnostic companies have pretty sophisticated tech stacks these days. Some hospital systems and some like clinical trial organizations also have really sophisticated systems for this. But like when you look at kind of the advantages that you have when you're sitting inside of one of these orgs, you typically have really good, very complete, very well secured connections to get, to share data between institutions. So the oncologist, the pathologist, and the diagnostic testing company can share data in a way that kind of allows them to get to a better diagnostic readout. And then you have data engineering pipelines that perform a lot of useful data cleaning and harmonization. When I talk about lowering the cost of working with data, a kind of, I think a great example is in kind of the trial matching space. Because if you look at clinicaltrials.gov, they have a very, I would say, like an unstructured way of representing inclusion and exclusion criteria, especially around diagnosis. Whereas inside of a hospital, inside of a diagnostics company, you might have a well-structured hierarchy for defining what a diagnosis is and how diagnoses nest together. And this can be actually particularly important in you actually see this as a really big problem in hematological cancers, as well as candidly in GI. There's a surprising amount of difference in how different doctors in different trials will describe similar diagnoses. And this can mean very substantial things from a, what medication is someone eligible to take perspective. So getting this cleaned up front, I think, can be really important. But I think finally the really big thing is that there is very high access to internal knowledge bases. And some of the time this can be, a medical team has gone through and done a great job of curating what are the approved therapies, what are, kind of in an easy to access way, what are the actionable mutations, so on and so forth. Some of the time, as we were just talking on gene expression, it's someone has gone through and curated what does different levels of gene expression for this gene look like, and where are places that you have to be cautious in interpreting this. And when you're inside one of these orgs, it's generally speaking, really easy to get access to the people who built these databases. They're oftentimes one Slack message away. But the thing is, fundamentally, there's no reason that these have to be proprietary. There's no reason that these can't be, accessible to patients. We have lots of examples in the digital health space where someone has gone ahead and built a patient-facing application that pulls data from EHRs, pulls data from testing providers, harmonizes the data, and surfaces it. There's always vagaries as to how you do that, but there's fundamentally, it's a pattern that we've seen elsewhere in digital health. And, if we think about, kind of curating a lot of that clinical information, knowledge bases like PubMed, or sorry, not PubMed, but, WebMD and a lot of the cancer societies have done a pretty substantial job of doing bits and pieces of that. But where I think it really does break down is kind of going back to, the fact that this data is very complex and cancer care is getting increasingly, kind of subject to a patient's individual molecular profile. A lot of those knowledge bases are written to be very general, and balancing the complexity of making it fit a broad range of patients while also making it very applicable to one individual who is looking for actionable insight for their care, given the information that they have, that I think still remains a really big gap. And that I think when you kind of couple the two of these together, you should get to a system that makes the data a lot more usable, that hopefully exposes data that is clean, that has like the, like clinically good interpretations and, kind of the right cautions on how to interpret it. But ideally that should allow us to build something on top where patients can really get into the meat of that data and ask the questions that they have at the time that they have it and get the insight that they need. That's a very broad frame of an idea that I'm working on. I'll pause there. Would love to take any feedback. I think I have one last slide, but would love to get any feedback on this.
We're big fans.
Well, it's good to hear. It's good to hear. So
You go, you wild cowboy, and we want to, benefit. So anything we can do to help.
yeah, that's actually I'll go ahead and I'll hop to that. I think I've hit on a few of these points in in some of the Q&A. So I think there are, like, if we had these, there are a couple of interesting avenues that we could go down to make this more helpful to patients. But I think some of the really big things that I'm would love to get feedback on. To give you a sense, I'm starting to go ahead and prototype this. Would love to get really good patient-centered thoughts on, like, what are the most impactful problems to go ahead and work in. I have a link to a survey on the next slide, where I'll go ahead and share the link in a second. You would love to dive further in offline. But here are some of the really big questions that I'm trying to dive into and understand. I think a really big one that I've actually, has kind of popped out today is, the challenge of convincing the clinical teams that you're working with about your concerns, about your questions. That sounds like a big problem. But I, would love to just pause here and get any perspective on some of these questions.
Just a process suggestion, Frank. We have a wonderful online discussion forum. So in addition to your survey, we can start a thread, or you can start a thread that just puts these questions out there, and we can have an interactive dialogue.
That's a great idea.
We had about 18 people here today. This is our live studio audience, and there's probably 3 or 4 times that many people in our community that would be happy to engage in a conversation online, but just couldn't make it at this time today. And it's also continuous going forward. So it can be people building on each other's comments. So that gives us also a safety valve. We don't get to everything today. We can get to it going forward.
Exactly. Yeah, I'll make sure to post the slides and the questions afterwards.
Anybody have any quick reactions to Frank's questions here?
I mean, so I'll just jump in here. I mean, I think getting the most complete view of our cancer as possible using complementary diagnostics, sort of a vision that I have.
Yeah.
Also being able to tell the story sort of like longitudinally,
Mm-hmm.
So you have prostate cancer, some prostate cancer patients on this call who can live with this disease for a while, right? And they go under many selective therapies, and that creates heterogeneity. Like understanding where the cancer has been, and also predict where it's going, and what are the cause and effect of the treatments that we have from a longitudinal perspective are really, really important.
Yeah, that definitely resonates, especially when you have multiple rounds of therapy, when you have combination therapies, they're applying selective pressure on the tumor in a variety of different ways. And that's something that I think is, a really big thing that drives response. It's a really big topic of research that we still have a fairly incomplete understanding of. And the only way to understand it is looking at the data longitudinally, which is, I think, very hard to do right now. That was a really big thing that we were working to solve at Tempus. And, I think candidly is one of the biggest problems in oncology today, especially like with the dominant clinical trial regime,
Mm-hmm.
where, you are, for good reason, looking at things in kind of a controlled environment, but that doesn't necessarily generalize to the real world.
Mm-hmm. Yeah.
So I would just building on what Brian was saying. I think there's maybe 3 categories here. There's the data, and then there's, as we've already talked about, the AI that would interpret the data, some kind of machine that can synthesize it and come up with recommendations and keep on top of the data and all the things that IBM Watson was supposed to be able to do. But the third thing that Brian's pointing out is modeling, disease modeling as well. And that's progression over time. But I think I probably mentioned this to you, but we're big fans of Bob Gattenby and the modeling that his team is doing at Moffitt Cancer Center. He's using evolutionary biology, he's using game theory, thinking of the cancer as a heterogeneous set of clones, and as you're perturbing that system with treatments, what is it doing to the system and how is that then progressing? So that whole area of modeling, I think, is a third category of something that would be part of whatever the software architecture that you're building.
Yeah, that makes a lot of sense. And candidly, that's, I think, been a pretty big gap that like both people in oncology and increasingly people in like germline human genetics are becoming aware of, because having the data but not being able to make an actionable statement as to like, from this is what's likely to happen, makes it just yet more abstract to reason over any of the data, which I think a lot of clinicians and a lot of patients really struggle with.
We're reaching the end of our time here, but I just noticed that Saeed Sayad is on this, and I'd like to make an introduction. Saeed, could you just sort of introduce yourself to Frank? Saeed is with Bioata, I think that's how he pronounces it, in Toronto. Saeed, are you able to just introduce yourself?
Hi guys, sorry, I'm in McDonald's in Slovenia, and I'm not sure. Can you hear me?
Yeah, the connection's kind of
a lot of
bad.
noises, right?
It's kind of bad. We'll do it offline, but I just wanted to call you out, Saeed, because you're a good connection for Frank to know as he gets into this work. I'll introduce you offline. Thank you.
Jeff,
you've raised your hand, Jeff.
Right. Yeah, I have some input on questions. What I know would be helpful to me, and I think for others, is, which is embedded in these questions, is a decisional balance. Not just, and I guess I'm looking more at quality of life, not just, here's the likely outcome, the percentages, but, okay, if I do try this new medication, what's the real world incidence of these side effects? You can look up on WebMD and you can see, 24 things and read, most people don't get these, but when you look at the clinical trials, if you want to dig down, you'll see that 45% of people had this side effect, and level 3 or 4.
Exactly.
Concern with that, and that information, at least in my experience, is never really discussed. And for me, that's an important aspect of making decisions on, based on quality of life. Do I want this side effect? Can I live with it? Am I likely to get the side effect? Not just the benefit of the treatment, but, do I want those side effects versus what I'm doing now that's working pretty well, but maybe this will put me into longer term remission. So for me, that's kind of tying that all together, and an information piece that would be very helpful for me.
Yeah, that makes a lot of sense, and I've definitely heard that before from folks that are kind of long-term managing their cancer, because it to your point, that's a very salient day in, day out concern. Yeah.
Okay, I think we're just past the hour, and I'd like to wrap it up. I'll stop the recording.
Of course.
Frank Scott,
I'll just hit this last one real quick. Here's my survey link. I'll go ahead and I'll post it online. I'm calling the working title for this either atlas.net or atlas.bio, but subject to change, subject to change. But, really appreciate you all, inviting me today, asking great questions, challenging me and giving me feedback. I really appreciate it.